Thank you all very much. Thank you, CJID, for bringing us up to speed on what you do and why you do what you do. Thank you for the impact you've had in the short period that you've come to manifest those great minds and great talents in driving processes in the Nigerian political, media, and economic space. Thank you. So we'll go on to the next session. Distinguished guests, ladies and gentlemen. This time around, they said we've not been smiling well enough, and that's why the moderator for this session is coming with a very loud smile. It is of the SMILE With Me Foundation. Please, let's all welcome Chioma Nwakanma-Akanno. So you can see now why she's of the SMILE With Me. Smile with me. Thank you very much. Chioma is a reproductive healthcare physician and advocate. She is the creative director of Dr Zobo, a prominent virtual health literacy advocacy platform dedicated to improving the health and rights of African women and adolescents. You're most welcome. Thank you. And on this issue, we'll be talking about advancing innovative ways and practices to reduce maternal and neonatal mortality. I stopped there because on the program you have, maternal mortality was repeated. So we do not want to, instead we'd rather immortalize our mothers rather than do it twice negatively. And to join our moderator, Chioma, founder, SMILE With Me Foundation, please let's welcome Dr. Raihanah Ibrahim. Dr. Raihanah Ibrahim, please. Thank you very much. I thought we were sure. Oh, okay. I was almost sure that I was sure. Thank you very much. She's principal at Solina Center for International Development and Research. We are thankful that you could make it here. She is a seasoned public health professional, a management consultant, and a gender advocate. And she's done extensive work in the northern part of Nigeria across multiple projects which have been funded by international donor agencies. We thank you very much, Dr. Raihanah Ibrahim, for obliging us with your presence. Thank you. May we also welcome Dr. Abiodun Adereni, Help Mom Africa. Help Mom Africa. Oh, okay. Thank you very much. Thank you. These lights, they don't want us to vote for some people. That's why they're shining. So, Dr. Abiodun Adereni, thank you very much for your presence here. Social entrepreneur who has dedicated his life to improving maternal and infant health across Nigeria. He's the founder and CEO of Help Mom. Mom as in M-U-M, as in mother? Oh, okay. Help Mother. Okay. Thank you very much. May we also welcome Dr. Nnaemeka Ajunwa. Do we have you in the house, please? Dr. Ajunwa? Nnaemeka? Oh, are you the... Okay. Okay. Thankfully, I didn't say she. Nnaemeka. Nnaemeka. Okay, I see the difference. Thank you. He's also a medical practitioner Dr. Ajunwa, trained at the University of Ibadan, I think, yes, the medical school, and with a dedicated focus on health systems strengthening. He's had 6 years of experience in clinical practice, public health, and digital health, developing and implementing initiatives that enhance healthcare quality and optimize health systems for sustainability. Thank you very much for obliging us with your presence. May we now also specially welcome Dr. Adaeze Oreh, the Honorable Commissioner for Health in Rivers State of Nigeria. Thank you very much. Thank you that you're able to make it over. It's quite a distance from Port Harcourt to Abuja, but she's here with us. Please, let's put our hands together for her. She is a consultant family physician with 2 decades of private and public practice experience, a member of the Governing Council of PAMO University of Medical Sciences. Is also a fellow of the West African College of Physicians, Aspen Institute, Royal Society of Tropical Medicine and Hygiene, and Royal Society of Public Health. Dr. Adaeze Oreh, thank you very much for coming along here this afternoon. So, with us. We'll have the session, and then later we'll take some responses from the audience. You have the floor, ma'am. Thank you.
Thank you very much, and a very good afternoon to us, Your Excellencies, distinguished guests, friends, professors. I was hearing a lot of professors earlier, so welcome everyone. I'm particularly delighted to be moderating this panel session because it's one that concerns everyone in this room. So I'll crave your indulgence to not just be in the hall, but also to pay attention and participate as much as we can. Thank you once more to every member of this panel, distinguished panel, I must add. I'll start by saying that it's no news that Nigeria is faced with many challenges. I mean, one of the targets of the SDG 3 is to reduce maternal and child mortality, and with the goal of ending all preventable child deaths by 2030 and reducing the maternal mortality rate to fewer than 70 out of every 100,000 births. Now, for that to happen globally, Nigeria plays a very huge role, and we'll be finding out what that role is as we continue in this session. I was earlier saying that Nigeria is faced with many challenges, but amidst the fluctuating economy and everything that seems to be facing us as a challenge, one thing remains constant in Nigeria, and that thing is sexual reproduction. Yes. In fact, the UNICEF MIC survey highlights that 8 million babies are born yearly in Nigeria. I think that deserves a round of applause. Now, I mean, we need no further proof that ours is a nation that places premium on childbearing. But with that leadership comes great responsibility. It comes at a great cost. Sadly, that great cost is that more than 3,000 babies die daily in Nigeria. And over 82,000 women, according to the new UNICEF report, die annually in this same country, Nigeria. And that is likened to a daily plane crash, because that's like 225 women every day dying from just trying to give birth, bring forth life. So that's something really distressing, something worth discussing, bearing 20% of the global burden of maternal mortality. It's not a leadership I think Nigeria should boast of. It's something we should work on. And so today, we're going to be discussing about innovative practices, because there is a need for innovative practices. And all these statistics I just talked about really underscores the significance of this panel discussion with the theme, Advancing Innovative Practices to Reduce Maternal and Neonatal Mortality. The panel's objective is to basically stimulate discussions on the current status, limitations, opportunities, and propose actionable steps and strategies for advancing innovative practices to reduce maternal and neonatal mortality. So once more, I say welcome, and welcome to our distinguished panelists. Okay, I'm going to be asking a question. I will start with you, our Honorable Commissioner, Dr. Adaeze. I wanted to find out, what are the barriers hindering the adoption of innovative approaches in reducing maternal and neonatal mortality here in Nigeria? And also, if you could highlight the innovations and practices that can be made accessible to expedite this process I talked about earlier. So what are the barriers and what can be done as regards innovation? Thank you.
Thank you very much, Dr. Chioma, very articulate moderator today. Thank you for CJID for inviting me to join on this very important panel. When we talk about maternal and newborn mortality, maternal and newborn health, while we're talking about innovation, I would like to bring to our minds the fact that sometimes innovation is not about something necessarily new. Sometimes it's about a change in our mindset, a change in our thinking. And we had the Millennium Development Goals before even the Sustainable Development Goals. And critical part of that Millennium Development Goals was ending maternal deaths, ending child deaths, especially neonatal deaths in newborn. So up until 2015, that was still not achieved in Nigeria. Then came the Sustainable Development Goals, as our moderator said today, with targets for ending maternal and newborn deaths. So you now wonder, if this has been at the top of the agenda, we had the every woman, every child movement, and still, we're recording some increases. There was a time when there was a marginal reduction in newborn and child death, but then a more substantial reduction in maternal deaths. But we're back to where we were, and even worse. And you then wonder, if this has been at the top of the global agenda, if this has been at the top of the national agenda and supposedly state agenda, why are we still discussing this issue now? And so a critical barrier, I would say, is intention. It's determination. And someone put it very eloquently back in 2006, and the first time I heard it, it stayed with me and has continued to stay with me. And the person was a past president of the International Federation of Obstetricians and Gynecologists, Professor Mahmoud Fatala. And he said, women are not dying because of preventable diseases. We know that maternal deaths are preventable. We know that newborn deaths are preventable. But they are dying because we have not determined that their lives are worth saving. So it's about intention, because I'll go into some of the innovative practices and protocols that have been shared even this year, and a lot of it is not really new. So let's speak about the emotive clinical trial that was just published in the New England Journal of Medicine. They conducted a study on 80 healthcare facilities in Nigeria, in Tanzania, in Kenya. Those are the countries that I remember. And Professor Hadiza Galadanchi was one of the foremost collaborators on that project. Professor Hadiza, I've mentioned her name, you know, is Nigerian. She presented this, it's published in the New England Journal of Medicine, and she presented it at the Gates Goalkeepers annual event in New York in September. Now, what is it? To quote her, a simple drape at the foot of the bed and a change of protocol. So what's the protocol? The protocol are the normal drugs that we know, tranexamic acid, the oxytocins, the usual regular examination of pregnant women, and escalating when we see that there's a complication, and a drape that measures the amount of blood loss so that healthcare workers will know at a glance when they need to escalate and get help. you've seen that there's nothing really new there. So those protocols have been in existence from the time when I was a house officer in 2003. From the time when I was a medical student doing clinical work in the late 90s. So basically, what this study showed was that doing everything together, bundling all these interventions together and not doing them one after the other, showed up to a 60% reduction in severe postpartum bleeding and death. 60%. So when we talk about these maternal mortality indices, we call the numbers. But basically, what do those numbers mean? Those numbers mean that a Chinyere somewhere, a Diola somewhere, a Husseina somewhere, and a Bifuro in River State perhaps, has died. And her family is mourning the loss. So I think it calls for a change in our mindset to adopt and institutionalize some of these research findings. They are not just to be published in papers and kept on shelves. They're supposed to be used for saving the lives of women and newborn so that these indices start to change. And of course, I can't run away from adopting technology. And basically, what's technology? Technology has been there. It's so that we have a mechanism where these deaths are reported. There is active and routine surveillance of maternal deaths so that interventions can take place and we can monitor progress. So I'll leave it at that because we still have quite some time together, and I'll share more perspectives. Thank you.
Thank you very much I love the angle you came with it, especially with intention and also active reporting and surveillance. Thank you so much, Dr. Adaeze. Now, piggybacking off that, we've talked about what we as a nation can do, Dr. Raihanah. I want to find out, how do these innovative practices in maternal health care align with international efforts and programs to achieve this SDG goal by 2030?
Thank you. Thank you very much. I would say that it's perfectly aligned because the SDG itself specifically calls for research and development, health reform, and whatever other innovative ways that countries can use to solve the problem of maternal and neonatal mortality. And speaking from a public health or development sector perspective, a lot of the work that we're doing, a lot of the programs that are out there are ultimately trying to identify, like she said, not necessarily always new things, but new ways of looking at things and new approaches to try to bring those things to scale. Deeper investments are being made to manage health risks, to make sure the finances are there to be able to scale these interventions, and of course, continue to learn and do research from ongoing work. So all of the international and local actors are aligned with this. There are many different accords, different conventions and declarations that have been made over time to continue to advance this innovative way of doing things. And I would say that a lot of that ultimately culminates in what we see in the kind of programs that we see coming on, right? When we go back to what causes maternal mortality in our setting, for mothers, the most common reason why women die is beyond, of course, the intention that she said, is postpartum hemorrhage or peripartum hemorrhage, which is people bleed out on the delivery table. And what are the ways, what are those things that are causing this? There's a number of delays that happens from when she even takes the intention to go to a health facility or to get care, whether that is even before she gets pregnant or while she's pregnant, gets the antenatal care, or when she needs to deliver. The delays that happen between when that decision is taken and when she gets to the facility, and the delays that happen in the facilities itself, whether it's them receiving her or making the decision on the line of care that is required for her, which is where emotive comes in to try to figure out what does this woman need per time based on her quantity of blood loss, right? For neonatal mortality, it's a lot of things around neonatal sepsis, all of which start as well from when the woman gets pregnant or starts to plan getting pregnant and all of those. So a lot of the reproductive, maternal, and child health programs that we have in Nigeria, including nutrition, of course, are aimed at reducing this, and a lot of innovation is being worked into making sure that this is a problem that is solved. I want to highlight a few other what we would call innovations or different ways of doing things or looking at the problem. There's also a portable ultrasound machine that was also discussed at the Gatekeepers event, which is a pocket-sized one that anyone can use to do an ultrasound anywhere. There's a community of people, researchers who are testing one single test kit that can ultimately detect all kinds of febrile illnesses. AI is being used to try to diagnose and look at data historically to figure out, what risks a woman might have. And of course, there's things around heat-stable products or heat-stable carbitocin in place of oxytocin, where we know that our supply chain may not be able to keep the integrity of anti-hemorrhage drugs like oxytocin in the health facilities. All of those are some products and technologies that are done in the clinical or diagnostics arm of things. But when we look at where a lot of the international donors come in as well to try to strengthen public health systems, a lot of innovation is going into that as well. And I would say that, again, the way we look at innovation is not doing something that isn't practical. Many times when people talk about innovation and technology, they talk about smartphones, and they talk about, high-tech stuff. And from where I sit every time, I'm thinking of that woman in a remote location in Zaria who does not have a phone, or who doesn't really know why, first of all, she doesn't even understand what you mean when you say use contraception, because she needs to give birth, right? She also doesn't understand why she should deliver in a health facility, because for her it's prestigious to deliver at home. A woman who delivers at home is considered stronger. Delivering at home is different from delivering at home with assistance. It's different from delivering at home with a traditional birth attendant, and it's different from delivering in the health facility. And of course, delivering in the health facility also has tiers. So women, a lot of innovation is also going into how do we educate women so that they understand. But beyond the woman herself, how do you educate communities to shift away from that norm of those harmful norms that ultimately perpetuate these harmful practices? A lot of these deaths are preventable, whether it's for the mother or the child. No woman wants to die giving birth. No woman wants her child to die. So there is something that's keeping them perpetuating these practices, and figuring out, using a behavioral science lens, how to do that in public health is one of those big areas that I think will help shift where we are regarding maternal mortality and those attendant issues.
Thank you very much. Thank you so much. I also like that you mentioned the behavioral science lens. Before we proceed, I would like to mention that we have one of our panelists joining us virtually, Dr. Francis Ayomoh. He's a public health physician, economist, and health system specialist who has implemented programs to strengthen PHC systems. He is currently a doctoral candidate in the Nuffield Department of Primary Care Health Sciences at the University of Oxford. He's joining us virtually, and at the right time, he's also going to be giving us his insights in this conversation. Thank you so much, Dr. Francis, for joining us this morning. Please, a round of applause for Dr. Francis. Okay, I'll be moving over to you, Dr. Abiodun Adereni. I am a big fan of your work. And, she just rightly mentioned that innovation is not just about high-tech solutions. It's not just about mobile phones, smartphones, and you are in the space of innovation. You work at the grassroots level. You work at all levels. So I want you to share your experience on what the current innovative practices are that have been implemented in this fight against maternal and neonatal mortality in your experience.
So thank you very much. So for me, I will be talking more about technology and how technology can help solve this problem that we have in terms of maternal and infant health care. And I'll be making reference to the work we do a lot at Help Mom Africa and how we are also we're also seeing how collaboration is making some of these good things that we do to happen. So the first thing I would like to say first is that, first of all, the problem of maternal and infant health care that we have is due to the fact that people don't have access to the proper healthcare services that they need, right? I remember in 2016 when I went to a community and then I was just starting out Help Mom. And then we just went there. We wanted to provide like healthcare services and healthcare information to mothers, telling them that it is not good for you to keep animals around you when you are pregnant, because when you keep animals around you when you are pregnant, if that animal has toxoplasmosis, your child can have congenital infection. And a pregnant woman showed me a primary healthcare center in our community and said, this primary healthcare center has been functional the last time it was functional was the last 4 years. That means in that community that is serving over maybe like 2,000 people, they don't have a functional primary healthcare center. So these women go to places like community health workers, traditional birth attendants to have delivery. And let me tell you the interesting fact here. In some communities, because of the bad road networks and the mothers can have access to safe birth items to have delivery, the community health worker can use the same blade to separate different umbilical cord from different mothers and their babies. And this is a very big issue that we are facing, lack of access. So what we are trying to do at Help Mom first is to bridge that gap and also see how we can solve the problem. So what we did first, the first product we launched then was just this birth kit. So that birth kit essentially contains all these essential items a mother needs to have safe birth. So you don't need, even if you don't have a good road network in your community and you are using the service of a community health worker, you will still be able to use that item to have a safe delivery in your community and the place that you stay, no matter how remote the place is. Then I discovered that the problem is even more deeper than that. First of all, the community health workers, the traditional birth attendants that attend to these people are not educated. So a lot of times, these people, they train from their grandmothers, right? So they see their grandmothers have deliveries and they just say, okay, this is how you remove the baby, this is how you do this. Some unhygienic practices like when the baby is out of the mother, they will use their mouth to remove the mucus. So that is how intense a lot of all these things happen in rural communities. Then we discovered that if we give these women kits and they go to these community health workers, and these community health workers are not still trained, we are not solving any problem. Then we decided to create something called like just short videos on things that they can do, hygienic practices that they can do, that they can use to save the life of a mother, hygienic practices on how they can wash their hands, just short videos. Then we put it on mobile tablet and give it out to like top community health workers in a lot of communities. So what I mean by top community health workers is that I like women a lot. Women are friends with other women. So when you see a top community health worker, she has like over 50 other community health workers that are training under her. So with that content, she can also give it out to all those people and they can use it in their community to save lives. And we saw the tremendous impact that can be. And I also discovered that, okay, now we are doing all these things. What about if they give birth to this child and we have to lose this child to a vaccine-related disease or vaccine-related death? That means everything we've been trying to do has just been a waste of time. Then I discovered that in Nigeria, we are still using paper cards to track immunization. There is nobody here that you have a child. When you go to an hospital in Nigeria, they're going to give you a blue card. I can't even remember how the color of it. They'll give you a card, and they will tell you when you're coming next, this is immunization, you should come, this is the date, and everything like that. Do you know the problem with that thing is this? I noticed that in a lot of dense rural community, when people don't know the importance of why they should do something, they will never do it. So they see a blue card in their hand and they say, oh, your child is ready to come for PVs this day. They just say, oh, I'm not even taking, I don't even know what this is all about. Then we created a centralized system. It's a mobile app. We know, don't forget, that a lot of people in communities, rural communities, don't have smartphones. So that is at the back of our mind. So I will explain how we solve that. We created a mobile app, which is a Ayomoh vaccination tracker. It's currently being used by Oyo State government now and Osun State government for the pregnant women in their state. So what happens is that when you give birth in a primary healthcare center in Oyo State now, you will download the app. So when you download that app, it automatically tracks all the immunization you are made to take your child for with the exact date and the immunization itself and the importance of those immunizations. And that in itself is helping the government themselves to have a centralized system in which they can easily track the immunization of people, nursing mothers in their state. Then we discovered another problem, which is if we are registering mothers to take their children for immunization and we are sending them SMS, they are using the mobile app, there's a fundamental problem also. I noticed that poverty and healthcare, they are interrelated. Somebody that's not eating will never think of going for healthcare. They won't even think of doing anything regarding their healthcare for themselves. So what we did was that we created this AI. We partnered with big organizations like Google, Vanderbilt University. Then we did a research. Then we noticed that women that earn below $25, that was like 2 years ago, they don't take their children for immunization, even if they are sensitized to take their children for immunization. Then the whole thing now was that, okay, we've seen this data, right? How can we solve this problem for these people? So women that earn below $25, they can't take their children for immunization. So we decided to use AI to solve this problem. So what it is, all the people that are registered on our vaccination tracker, the AI system reads their data and knows the barrier on why this mother will not take her child for immunization. So if all of us were in this building now, like 5 of us are here, and we are registered on Ayomoh vaccination tracker, if the AI system can read my data and say, the reason why I won't take my child for immunization is because I don't have money. So the intervention that we should provide is to take the immunization to the home of this mother or provide a form of stipend that will help this mother to take her child for immunization. The AI system can read Chioma's data and say, Chioma has money, but she doesn't understand the reason why she should take her child for immunization. Then the AI system will say, we need to provide more sensitization to Chioma with a chat box or call her and sensitize her and tell her that those things that you are hearing about vaccine is a lie. Like now, let me give an instance. HPV is out. HPV, like for girls between the age of 9 to 14, you hear mothers say that they've had that vaccine will prevent their child from giving birth. That's why they won't take their child for that vaccine. There's a lot of disinformation aside from poverty that is out there. So what we've done at Ayomoh is to create technology innovations from the lessons we learn on the field, and we use that to improve maternal and infant healthcare. I think I'll talk more about other things.
Now you know why I said I'm a big fan of his work, eh? Thank you so much. And I also have to highlight that I love the example he used when he said Chioma has money. Thank you so much. I once heard of a story of someone who was told, let's say you are poor. And he said, even in that your example, I can't be poor. So thank you so much. I love the fact that you kept thinking of solutions every step of the way. But the truth is, Dr. Adereni alone cannot think of all the solutions to every problem that we have. And that's why we are all gathered here. There's something you can do. There's something we all can contribute. And hopefully at the end of this conversation, you can find out where you fit in this whole puzzle of maternal health mortality prevention. Now over to you, Dr. Nnaemeka Ajunwa. We've been talking about innovation, so great that we're about to dive into this area. How can data and evidence be effectively utilized to identify and prioritize innovative practices in maternal and neonatal healthcare. I know you're the digital health lead of Reliance Health. So, what in your experience is very effective in identification of this? Thank you.
Okay, so thank you very much. And thanks for, to CJID for gathering us here to talk about this. I think that to start, I would start by saying that a colleague here who spoke before me has already more or less given us multiple examples where data has been used to either come up with solutions or make solutions better, right? So I would like to think of these questions in two ways. One, how do you use data to identify problems, identify solutions? And how do you then use data to make it more effective, right? So in identifying problems, you're always thinking about what is the real problem here? How big is this problem? What's contributing to this problem? And the only way you're able to have some certainty to each of these questions is by, what's the evidence? What's the data? How do we know what the statistics say about our maternal mortality rate in Nigeria? That's because of there is some data, right? If you were to go to a committee and said, women are dying, women are dying. But how do you quantify that data and say, oh, women are dying because, mostly due to hemorrhaging on the delivery bed? That's because some data is being captured. Somebody's looking into it and saying that, yes, women are dying. This seems to be the big problem, right? Then you then go into things like, what are the contextual factors, right? In some cases, you're looking at, oh, our cold chain isn't so effective, right? So if women are dying because they are bleeding a lot, why are they bleeding a lot? You then go deep into that. You find out that, oh, it's because, the oxytocin, they didn't give oxytocin, so it's shortage. In some cases, they gave oxytocin, but it did not work. You're wondering, why did it not work? So that's how data, drives you to do that actual problem solving before you are then able to say, oh, we need to improve our cold chain system. And, even before you then go into we need to improve our cold chain system, there is a bit of what in that cold chain system is faulty, right? So data is the way, it more or less gives you a pathway to identify the actual solutions or the different, causative factors to the big problem, right? So then if you go into how can you then use data to make this, to make your solutions more effective, right? I like to think about it's you need to have quality data, robust data to be able to make effective, decisions, identify the real problems, and come up with effective solutions. So I'll go back to the example that Dr. Adaeze has used, right? So emotive, people know that people have been dying due to this reason, right? But they've gone back to do a research, collected as much data, and they've come to say, you know what, there's a possibility that people are not quantifying the blood loss properly. So how can we help people to quantify the blood loss better? And they've come up with a solution that says, let's drip. You understand? So people have been saying, oh, quantify by using pad, quantify by using this, but there is now a let's also drip. People might not be quantifying properly. And that's how data makes your solutions, more effective. So, and for you to have quality data, robust data, there are different aspects to it, but it starts from collection. So you collect data from somewhere, right? We all have the idea of to collect data that is, really accurate and the likes, we want to digitize. So people are a bit skeptical. With paper records, you have a couple of errors, you could get missing and the likes. So everybody talks about digitalization. But in our context, that might not be very possible, especially when you think about the rural areas. So if you were to take a computer to the rural area of Zips, say Zamfara, the people there probably don't know how to run a computer. There's probably no internet to connect to any database. There's probably electricity issues. So there are a lot of contextual factors that would not really allow that solution to come, to fruition. So you're then looking at building upon what we have. So we have paper-based system, right? Is there something to make it better? There are programs that have come up with a couple of, specified record books that people can fill in. They've tried to streamline the way people capture this data. And a lot of these programs, this data is eventually translated into digital data in a lot of these programs. So you'd have a typical program where you have some record book in the facility because, it doesn't make sense to put a computer there as we stand. So they capture it in some paper, but someone is tasked with transferring that paper to a digital, space, a digital database, so that we can go to the next stage. The next stage, we're looking at things. How do you store that data such that it's accessible to people who need to make the decisions? So you have a lot of public health, organizations. You have the government. You have private individuals who are interested. You even have people here who are very much interested. Well, how can they know where do I come in if they don't have some access to some data to understand the problem? So you need to store it in a way that is accessible to people. Why we know some of this research is because somebody has taken it up, stored it somewhere, and we can easily tap to it to say, okay, this is the start. I don't need to go and start looking for how many women are dying anymore, right? And then the analysis. There are people that would do analysis. It's not everybody that's going to go into the analysis. People need to go into that data, look at it. What are the trends? They need to be, really clear about what's the trend, what's the cause here, and they're able to then use that to advise. A very key part of analysis, especially for innovation, is thinking about what's the cost versus impact. So we are in a very low resource environment. The budget, I think our Nigerian budget is somewhere around 5% for healthcare. The advice is somewhere around 15%. So we are way off. So when you have so little money for a lot to do, you're thinking about what's the one that gives me the greatest impact. And this is where analysis can help you. So if you understand that this problem is really big, and you're able to use data to quantify cost versus impact, you're able to then prioritize this option over this option, and this option first before this next option. And then you go into the instance like prediction using of AI. So, he has also given us examples where they've used AI to say, predict, oh, this, we should do this. AI has said, this person is probably not going for immunization because of this. So let's do this, right? And that's how, data can help us to identify the problem. It can also help us to improve on the problem. Thank you.
Thank you so much. Thank you so much, Dr. Nnaemeka. I thank you for highlighting about the importance of building on existing structures. And I think this is taking us to the next part of the conversation before we hear briefly from one or two people in the audience. You mentioned data and, gathering data, making sure that data is available for people here. I'm very sure more than one person here, more than one because I am one, here has had the bottleneck of looking for data to report as media people. I've had people in the media calling me and saying, Dr. Chioma, please, do you have statistics of so and so and so? And so there's that bottleneck of, having data in public domains and also data analysis, as you mentioned. So now that takes me to you, Dr. Francis. Dr. Francis Ayomoh online. You are the health policy person. You are our expert here. So we want to find out, as much as we have great intentions as medics and people in tech, coming up with innovations, what potential policy interventions and investments are required to support the adoption and scaling of all these beautiful, innovative practices that we've heard about, these recommendations for maternal and neonatal healthcare? Thank you.
All right. Thank you very much, Chioma. I don't know if you can hear me. Am I audible? Okay, thank you. So I'll start by commending CGID for picking this topic, and just link to the issue about data. As mentioned, I'm a doctoral researcher at the University of Oxford looking into primary healthcare. And when I started my work, the reference data I was using for Nigeria, so I'm working on something related to tax shifting for maternal health services in Nigeria. And the reference data I was using was the 2018 maternal mortality report. And so that's data already. And at that time, Nigeria and India were almost at par as to their contributions to global maternal mortality. But voila, 2020, a new report comes out. India has done so well, dropped almost half of its maternal mortality. But guess what? It looks like they heaped the excess maternal mortality on Nigeria, because we were now leading globally with 28.5%. Now, what's my worry about when we talk about data? I agree that a lot of the data we need is not there. But the other problem is even the data that's available We're not acting on it. I looked around when I saw that report when it came out early this year, and there was no crisis declared anywhere that maternal mortality in Nigeria is a problem. Now, I know that stakeholders are making a lot of effort, but now in line with the question you asked, I think there's a lot more effort that needs to be done to drive innovation. And I want to be both from the policy point of view and from the programming or intervention point of view. Now, I want to pick up from where Dr. Adaeze had mentioned at the start of this session, where she said, innovation does not necessarily have to be something new, and it doesn't always have to be something maybe technologically driven. It might just be a new or a better way of doing things. And I've heard all the panelists speak, and anytime we're talking about innovation, there's always that temptation to talk about digital stuff, high tech, but we forget the basic things. Now, what's the basic thing? For me, no matter, in as much as I appreciate all the work that's been done with tech and stuff, there's a point where tech stops and human beings have to do some work. Now, I strongly posit that it appears that, again, I'm not trying to trivialize the efforts being made, but I think we have not even really started on the real issues as to how do people get access to services at the last mile. One of the panelists talked about the different delays in maternal mortality. And yes, you could use tech to improve people's early decision-making. You could use tech to map, like one of my senior friends and researchers is doing, map facilities and let people get facilities earlier, or convince stakeholders to build more facilities closer to the people. And even for the fourth delay, you could use tech to make people more accountable about maternal deaths. But one of the key causes of maternal deaths, which we seem not to be doing enough in, is how do people get services at the facility level? Now, when there are two major things, and that's the area I want to talk about quickly. I know there won't be too much time. What are we doing about the human resources that are supposed to deliver these services on the one end? And on the other end, what are we doing about the infrastructure they need to deliver the services? When I was in medical school, one of my professors was a neurosurgeon from Saudi Arabia. He came back, he couldn't do anything because there was nothing in the hospital. He had to bring his personal equipment to the hospital before the neurosurgery unit could do stuff. Now, the problem is, again, I know these comments are not general. Some states are doing better than others. But based on my research and my interaction with different stakeholders across the country, we do not even have enough human resources for health to meet up with these services. And the few that are available are not, like one of the colleagues, I think Dr. Abiodun had said, they are not, some of them are not well trained, they are not well motivated. In fact, my research found out that in a lot of facilities, particularly the FCT is the focus of my research, many of the healthcare workers are not remunerated. They work on the title of volunteers and they just get monthly stipends every day. Now, how motivated is that person going to save a life? We've talked about the work that Professor Hadiza Galadanchi has done, beautiful research in the emotive study, the other work done by the likes of Dr. Bosede Afolabi, the IVON study about how you give IV iron instead of oral iron in severe. These are beautiful interventions. You can't fault them. The problem is who will deliver those services. So if we always just talk of innovation, again, like I know, you can only do what you can. There's a limit, there's a point where the government has to come in and possibly maybe development partners with intentional effort to address the problem. So we have policies. I'm studying one of the policies, the tax shifting policy in Nigeria, which a lot of states have adopted. It's a beautiful policy. What does it say? Because we have shortage of healthcare workers, let's engage more junior health workers to be those that are maybe less qualified, train them, support them, motivate them so that they can bridge the gap that we don't have enough doctors or obstetricians, especially at the primary level of care. But 2014 till date, when the national tax shifting policy was set and has been reviewed about twice now, I think the latest version was in 2022, we have the policy on paper, but in reality, the actions are not really there. Like I mentioned in the FCT, a lot of the healthcare workers are not formally employed nor remunerated. So talking about innovation, for example, tax shifting can be seen as innovation. But now, are we supporting that new approach to delivering health services? We're not doing as much as we should do, because yes, it's one thing to have the policy, it's the other thing to take the necessary actions to make that policy come to life and actually expect results at the end. Because again, I was looking at the policy document and we're trying to track how much progress is being made with tax shifting. And the only indicator to track progress was how many states have adopted the tax shifting policy in Nigeria. So there's a lot of, so the problem like with technology, I agree that we can put in policies to make technology more interwoven into what stakeholders are doing at primary level of care. But I think where the main work should start is, how are we bringing, because as we all know in Nigeria, the problem is not the availability of policies. I can bet you, if you want the policies for anything, we're going to bring it. Nigeria prioritizes maternal health in almost all policy documents. In fact, when I was studying the history of the tax shifting policy, maternal mortality was one of the major reasons why the country said, no, we must start tax shifting, because women cannot and children cannot continue to die because we do not have enough health workers. So there's a policy, but we now need to go beyond the policy on paper to now making sure that we have these health workers on ground, they are well trained, they are well motivated, and also beyond the health workforce themselves, there is need for infrastructure. Do we have the little equipment that these health workers are going to use? And mind you that sometimes these things are not expensive. It just means that we need to be more intentional and honest with ourselves about how to move policy from being a policy on paper and translating it into practice. So I'll stop here for want of time and maybe continue in the next time. Thank you.
Thank you very much, Dr. Francis. You know, I saw that, or I heard that subtle shade on Nigeria when you talked about us having a lot of policies on paper, which is true. So the issue is implementation. That brings me to this general, just for us to round up. There's a general question I have for every panelist here, and you would have your own time to respond. I would start with you, Dr. Adaeze. Talking about how can innovative practices be made sustainable and ensure long-term impact in reducing maternal and neonatal mortality. While answering that question, I would also want you to add to, you know, he just mentioned, one of the things he mentioned was healthcare workers. We have a Nigerian brain drain, right? So how can healthcare providers be trained and equipped to effectively implement all these sustainable, innovative, or sustain innovative practices here in Nigeria? Thank you.
Thank you very much for that question. And thank you, Dr. Ayomoh, Dr. Francis, for hitting the nail on the head. We can't escape the impact of people on implementing any of these policies. And so the healthcare workers, the people are the bridge between the policy and the patients. And so when I'm talking about people, I'll talk about it from two aspects. First will be the healthcare provider aspect, and then second would be the patient, client, family, community perspective. And so the first, which is the healthcare worker, as we've mentioned, we all are aware there's a brain drain. And this brain drain is not something that ended yesterday. It is something that is ongoing. And in some facilities, you have a situation where entire departments are leaving. So from the head of the department to the clerk in the department, they are leaving in entirety. You have some departments that just leave the head of that department to do everything because the entire substance of healthcare workers has left. And so when we interrogate what are the situations and the conditions that are making people leave, we also have to be realistic that not everyone wants to leave. A lot of people are pushed to leave. And so there are people who, as at today, were adamant that they will not leave the country. And by tomorrow, maybe something happens tonight, maybe something happens tomorrow morning, to themselves or someone that they love, and they decide, to hell with it, I'm done. Nigeria cannot happen to me. And so that is the reality that a lot of our healthcare workers are faced with. And when we talk about the brain drain, Japa syndrome, and the deficit in human resources for health, it's not just a health issue. A lot of times it's an economic issue, it's a security issue, it's an education issue. And so until we get to the point where we look at this thing in totality and not just call all the CMDs, the chief medical directors, or the medical directors and the commissioners for health to discuss the problem of brain drain, we're not going anywhere. Until that discussion is a discussion that is held with not just people in health, but people in the security forces, people in administration at all levels, people in the economy, people in finance, people in agriculture, people in education, we will not solve the brain drain problem. And so, unfortunately, because of health and the negative impact that exit, that torrential exit of healthcare workers will cause on the lives of and well-being of people, it seems as if it's a health problem. It is not a health problem. It is a national, a state, and a community issue. And so when we talk about sustainability, how do we address those factors? How do we address the security issue that is a direct attack on the healthcare system, the educational system, and the fabric of our communities? So that's on one hand. And then, for those who are here and those who we seek to attract to deliver these healthcare services, what are we doing to attract them? And the truth of the matter is that a transport stipend at the end of the month is no motivation. These people are volunteers, they are working in their communities, they have community trust, but they have families, they have mouths to feed, they have responsibilities. And so until the system motivates them to contribute their services, they will continue to look for other avenues to survive. And so for those who are in the system, my answers are coming from a place of someone who is in policy making at the government level. And so this is something that I am taking on as part of my job description. What are we doing at government level to attract, retain, and sustain the healthcare workers who we have on ground to deliver these services? Because even with technology, you need somebody at the other end of the tablet or the phone or the desktop. Even in terms of the delays, the first delay, we know that a lot of the delay for the person to even determine to go to a health facility is economic. It's economic. That's why a woman will say that she's waiting for her husband or her brother to come and take the decision because she does not have the wherewithal to seek that health care. And then the healthcare workers are not there at the point where the healthcare is to be delivered because there's definitely a shortage. Since my assumption of office, I've been going to several rural community health facilities. And I can tell you for sure that seeing a doctor in any of the facilities is not a given. There are somewhere there will be doctors on ground, and there are a lot where they are not. And I cannot, because I am the Commissioner for Health, start interrogating why is that doctor not on seat. I know the reality. You have a doctor or a nurse that is covering several communities, some accessible by land, some by only water. How will that person deliver the services that they need to deliver? And so we can't escape this discussion where we all come to the table and interrogate what are those factors we need to put in place so that our healthcare workers are comfortable. They are able to deliver the services that we require them to. India has made substantial gains in addressing maternal and newborn deaths. A lot of that was, they dedicated a lot of thinking and funds into motivation of people working in rural facilities. And so you would have people graduating and be assuaged by the number of offers to go and set up practice in a rural facility with very attractive options. So for a lot of them, their family members were asking them, are you crazy? When they said they are not going to the rural facility. because of how attractive those motivational factors were. We know that it's not rosy being in a rural or remote facility, especially where you have families that you are building. And so that is where we have to come to the point where we are making those facilities attractive, but we have to make them secure as well. And so, in a nutshell, for sustainability, we all have to look for a multi-sectoral approach to discussing the issue of brain drain on the health sector. It is not just affecting the health sector, it's affecting the general economy. And until we get to that point, we will not make any gains.
Thank you so much, Dr. Adaeze. Thank you so much. A multi-sectoral approach to brain drain, definitely. I think your position and your contributions here are testament to the fact that we need leaders who are not just, well grounded in their IQ, that's the intelligent quotient, but also their EQ, that's an emotional quotient, because it takes intention, as you earlier mentioned, for us to drive and sustain innovation in maternal health. Now we're going to just briefly, before I continue with our panelists, we'll go into the audience. I know we have some questions online, and I've seen a couple of people taking notes, and I'm sure one or two persons have questions. So if you have questions, you could just raise your, oh, wow. Okay. How are we going to do it? I would leave that to you, sir, to just decide on how this will go. We'll just take a few questions, and then we would have them answered. Whatever questions we are unable to answer today, I'm sure there will be an avenue for you, or even in their responses, you might find out you have questions that have already been asked. Thank you.
Thank you very much. We'll start from here.
Thank you. I just have a question for you, and no intention to put you on the spot. But all the five papers are excellent. But you came up at the beginning to emphasize intentionality. And I understand that you are also a political commissioner. And then this need for a multi-stakeholder approach. Will it benefit from the intervention of our government? Because it looks like maybe there is no government, because there is no intention for women that women should not die at childbirth. Then it may also mean that other problems happening in Nigeria means that there is no good intention on the part of those who matter most for anything worthwhile to happen in the country. That's worrisome. But do you want to?
We'll take them.
Okay.
Just take notes. Prof, you had, yeah. We'll come to you.
I am really, really thrilled with the contributions of the panelists. Like Prof said, excellent. Now, mine is not a question, just some minor contributions. In the late 80s and the early 90s, I did some significant assignments which contributed to maternal and child health. One, I got a grant from the Ford Foundation, I think 91 or thereabout. I did a study on maternal and child health practices among nomads in Adamawa State. 2 papers were published in some prominent journals. Another one, I got another grant from the Planned Parenthood Federation of America. I think that was 93, 94, I can't remember. I did some work in some local governments in Borno State. And on the day that I presented the findings, people almost shed tears. Local government, I never knew the kind of conditions in the local clinics and the way people were living in some parts of the state then. There and then the government made significant commitments. And some contributions also came from outside. But the third one was something that happened. I don't know, some of you may know Professor Una Lister, one of the most prominent gynecologists that worked in Nigeria. Something happened. The 3Ds. A lady was in labor in her village for some days. Then she couldn't deliver. An attendant was brought. There's what they call yankangishiri in Hausa, expanding the organs for the baby to be able to pass. In the process, they did it to the extent of the razor blade impacting on the jaw of the child. And then the lady, still she couldn't deliver, in pains, were brought to the teaching hospital. And by the time the doctors worked and brought out the dead baby with all the razor blade impacts and all of that, Professor Una wrote something, and I took that paper and wrote a paper which I entered into for a competitive entry in BBC World. And it won an international prize. BBC gave me a prize, and I became member of African Population Council. So many things. Even in Nigeria, I was part of the policy drafting for national population policy, adolescent reproductive health, so many things. Then I realized that I was drifting from my communication business into health. So I gradually withdrew. And I was seeing so many things I didn't like. Because I was given so many assignments by Ministry of Health, by UNFPA, by this, by that, so many assignments. I gradually pull out. But one thing which my students in communication could do, and which I introduced some topics which I mainstream into the kind of teaching that we were doing. Some of us who are teachers can take up some of this, mainstream into what we teach our communication students for them to be conscious and encourage them to be writing on some of these things. This is not a topic that can bring money to journalism. So many of our media people are not even interested in going into coverage of this because it will not give them any cover. And this is the era of commercialization. So we need to encourage our students to develop interests. And for those who are in the industry also to develop interest, because I know there are so many negative things that are happening at the lower level. And that was even partly why I decided to just change my focus from these issues to my mainstream media activities. Thank you.
Thank you, Prof. Thank you, VC. Thank you, Chairman Board. Yes, Madam.
Thank you very much. My question is directed at the CEO of HEPMOM. I have a question here. And in trying to reduce this maternal mortality and neonatal mortality, is it possible to deploy these digital approaches, some of which you have recommended, to these IDP camps or displaced camps where we have women who are there because of the flood situation or humanitarian crisis, and sometimes we have fewer PHCs there, or some of them are not even existing? Is it possible to have these approaches deployed there? So that's my question. Thank you.
Thank you. We want to come this way. Be ready, panel. We'll take some more from this end and then go the other way. This has to do with our mothers and our sisters.
Thank you very much. My question is that spoke about the Help Mom Foundation. We've seen that, talking about the rural area especially, this issue of antenatal drugs, there are some drugs that mothers will take. I think when I was in Maiduguri, there was a period of time at the teaching hospital whereby mothers were having stillbirths. And these stillbirths were common and also deformed babies. So there's a particular doctor that took it upon himself to find out what is going on, because some women were getting scared of actually going to the teaching hospital, the University of Maiduguri teaching hospital itself, because of the increase in mortality and the having deformed babies. And I think the doctor found out that there's this, I'm not too sure, I think he took it to NAFDAC, there's this German product, antenatal drugs, that mothers were taking. He had to go to the delivery rooms, delivery ward, and they found out that there are these antenatal drugs that were being taken that was causing that. So he took it upon himself to come to Abuja, take it to NAFDAC, and NAFDAC banned that drug. And so my own question is, as regards reach, those people at the rural areas that won't know, what is the organization or your foundation doing to cut across the centers? My name is Nurat Audu, University of Abuja, Department of Broadcast Media.
Yeah, we have another lady here.
Okay, my name is Joyce Bawun. I'm a reporter at Radio Nigeria, Highland FM in Jos. My question is, the increase of CS, cesarean section, does it show that it is an advance of technology or a failure, or rather maybe due to brain drain in the country? Because most women now, they don't want to do CS. They feel it is not my portion to do CS. And you see them dying. When I went to give birth to my son, the woman beside me died because she refused CS. So as journalists, we want to be informed too, so that we'll know what to tell these people, since they are not here. And then my next question is, I was waiting to hear more of the solution, but I was just hearing still the complaint, sorry to say, in the sense that, okay, we don't have health givers again, like these nurses, midwives are all running. The thing is, should we continue to suffer because we don't have anybody to take care of us? People are dying. What do we want to do now? If we don't have them, what can we do? What can be done? What can government at all levels do while we wait for more doctors to come on board?
Thank you very much. We still have another lady here. Tell us your name.
Okay. My name is Hannah Egia. I work with Credit Advisory. So it's been an insightful discussion. We've been talking about data, talking about innovation, but then the role of the media cannot be overemphasized. Now, the media is important in disseminating health information. You know, it's important in improving health knowledge and also changing health behaviors. Now, we've talked about innovation, app. The other doctor mentioned app, and Dr. Raihanah mentioned how they are trying to curb maternal mortality. Now, my question is, have there been community engagement efforts made by these organizations to curb this mortality? And if there are there success examples of media campaigns or communication strategies that have significantly impacted mortality health outcomes? And if there are, what lessons can be learned from them? Can you share them with us so that if we need to engage the community, we would implement some of these lessons you would share with us? And then what we need to also ask ourselves, I mean the media here, how can the media amplify the voices of marginalized communities? And what role can we play in promoting community-led initiatives to address this mortality rate?
Thank you very much. Panelists, I hope we are taking note. What do you want to do, moderator? You want to respond to this and then we'll continue?
Yes, I think at this point we just respond, and then I just saw a couple of hands that actually went off.
You want to take some here? Or
no,
you
we'll
want
respond.
to and then we'll continue the process?
Yes, here, just
right.
here.
Okay, thank you.
Yes, so, okay, just to direct the questions. Dr. Adaeze, you already had your question cut out for you. So you take your question, you respond to that. And Dr. Francis, are you still with us? Is he still online? If you're with us, Dr. Francis, I would direct the question about what can we do to reduce brain drain. You talked about that, and someone mentioned that she needs more solutions around that. You have your questions already directed to you too. Then Dr. Nnaemeka, please, if you could mention about successes around community engagement. We had that question. And Dr. Ibrahim, if you could also talk about the CS and why someone asked a question about CS and why there's that rise. So, Dr. Adaeze, thank you.
Thank you very much, Prof, for that question about your alarm regarding intentionality with addressing maternal and newborn deaths in the country. And I believe I spoke to it to a certain degree when I was speaking about intentionality. And we're at the point where we need to call on this crisis of maternal and newborn deaths. It is inadequate that between the 2018 trends in maternal and newborn death reports by WHO, UNICEF, and the World Bank, and the 2020 report, Nigeria has moved to the top spot in maternal deaths. It is when I was talking about the multi-sectorality, it's important that we don't take these statistics as just mere numbers, like I said. And so when we're interrogating performance, like for myself, my KPIs include maternal death, newborn deaths, under 5 mortality. Those are the KPIs I will be using to interrogate and assess my performance in my role. And it shouldn't stop at that level. It should be something that we internalize at the state level, at even the local government level. And so community engagement is also very important. Somebody talked about mentioned media. Whatever initiatives that we are proffering to be implemented for the improvement of the health and well-being of our people, we need to engage and involve the communities. And a strong part of community is media. We should have and encourage a robust civil society, because we cannot on one end of policy making or healthcare provision say that we want to improve facilities when those critical voices who are at the other end of the spectrum and are expected to receive the dividends of the improved facility are not allowed to have a voice. And so one of the ways that I've practicalized this in my state is by regular engagement with civil society at the community level, so that the voices I'm hearing from Asaritori local government are different from the voices I'm hearing from Ikwere local government or Opobonkoro. Because we know that the context is different for different communities. And until we get to that point where we welcome those voices and not see it as an attack and not be in the defense, but see it as a tool that we can use to improve quality and improve services and save the lives of our people. That is the approach I believe I am advocating for as I speak to intentionality. Let us practicalize these numbers. Let us humanize these numbers. They are people and they are families and they are citizens of this country. So I hope I've addressed that question, Prof. Thank you.
Thank you so much, Dr. Adereni. Could you answer your questions? Thank you.
Yeah, so let me first go back to the last question you asked about. So first, let me even go to the fact of brain drain. I'll just mention something. I think it is important we start paying our doctors what they deserve, because that is one of the major problems as I see insecurity. It is important that, and I will say it again, and this is something the government should look into, it is important that we start paying our doctors what they deserve. Just do a normal survey. Take 100 doctors in the UK, ask them, why did you leave this country? The first thing they will tell you is that as a first officer, it doesn't make sense for me earning 200,000, right? My elder brother, I'll use my elder brother as an example. When my elder brother finished serving in Unizik, he was working as a physiotherapist and he was earning 120,000 a month. To me, that was ridiculous. He was one of the best graduating students in his set in OAU. What does that mean? He's in UK today and he's doing so well. He has some physiotherapy clinic he has even established himself. So what am I trying to say? If we make the system good for people, I know insecurity is also one of the problems why people leave, but we would be able to see more people stay. So I think the overall payment system for medical personnel in this country should first be cancelled, and there should be a total review. If our senators are getting, I don't want to go political, so let's not do that. So we also, a lot of people talk about the progress that India has made. One of the things I noticed, or one of the things I discovered, was that India themselves, they work a lot with local innovators, right? One of the reasons why someone mentioned that in 2018, Nigeria and India, they were up to par in terms of maternal and infant health care. Today, India is far behind us. What did they do? They looked at a lot of local innovators, a lot of startups that were building innovations in maternal and infant health care, and they incorporated some of them into the healthcare system of the government. I'll give an instance. Amma is a social enterprise in India that helps to make mothers know about risk assessment, all those things. Today, Amma has been incorporated into the government system, and Amma is serving over 10 million women every month. That kind of scale can't happen if the government is not involved. Sorry to say, I think the Nigerian government needs to do that. But I think the problem the government makes, I don't want to talk about the government. I think what the government needs to do is that they need to start looking at working with innovators to scale their solutions. One of the things that we did in Oyo State, for instance, was that we discovered that if we have to go to all primary health care, if we have to go to all mothers and start telling them that download our vaccination tracker, we're going to spend a lot of money. We approached the Oyo State government, let us infuse our vaccination tracker into all primary health care centers in the state. And every single month, we give you the data about how people are taking their children for immunization, the number of people that are registered on the vaccination tracker. We have like this agreement around data sharing and everything. And that helped us to scale. We moved from we were able to register over 1,000 in 3 months. And currently now our vaccination tracker has over 100,000 nursing mothers registered on it. That is how we can still scale at impact. And I also want to say something. The government should not think of going to replicate some of these solutions themselves, because the government is not good at implementing and sustaining solutions. That is just the fact. We have to be honest with ourselves. The problem here is that the government must look at how they can work with innovators and co-create, co-develop, co-implement together and scale these innovations to people that really need them. The other thing I also want to mention is community. How do you carry the community along? See, one of the things, I know if you stay in Lagos, you know all these Agbero people that collect money that stop cars. If you go to a lot of all these communities, there are people like that, but they are not Agbero. They will tell you, before anything can happen in this community, you have to pay us. You have to pay us. And sometimes you don't have that money. One of the things you can do is to re-engineer their minds. You tell them that if you don't do this thing, your wife can die. They want us to do it, we'll go. So sometimes they will be adamant. They will say, no, Emma alone now. Like that's a Yoruba statement. But you have to see how you can carry them along. And one of the things I've seen that worked so well is engaging community leaders. Because some of these guys respect community leaders. When a community leader gives you an approval that don't touch them, let them do everything they want to do because it's for the benefit of the people in the community, they listen. So that's one of the approach I feel that people can actually engage community. So the two questions that I was also addressed to me in terms of IDP camps, like I said again, I believe that you can do so much with the government involved. I believe in some states that we have these IDP camps, if we can partner with those governments in those states and we can deploy this solution, it can reach those people in those places. But if we say we have to go do it ourselves without involving the government, we are going to encounter resistance. The people can tell us that they are not approved, they don't want us to do it, that we have our own motive. But if we have the approval of the government, we can do so much and we can reach out to more people. And the other thing about drugs, that someone mentioned drugs around that leads to abortion, if I think, in case I get that question right. I think, yeah. So I think one of the things that people need to also do is to report these cases early. Sometimes these community health workers, they have connections with maybe doctors that some of them talk to learn from. And if they are reported early to some of these people, it can get across to the right people and the right actions will be taken. Thank you.
Okay, Dr. Ibrahim, if you could answer your question.
Thank you very much. I just want to start by saying I stopped practicing in the clinic a couple of years ago, but I will attempt to answer the cesarean section question. Cesarean sections being offered more now, is that an issue? Is that a problem? I would say it isn't, because what matters the most is that we have delivery that is safe, the mother is safe and healthy, and the child is safe and healthy and survives the neonatal period beyond infancy into adulthood, right? It doesn't matter if that baby was delivered vaginally, assisted vaginally, or cesarean section. What matters is the quality of care and the quality of life that the mother and the baby receive during and after the period. But is it an issue of concern for communities? Absolutely, because like I said, there is a big stigma that is attached to this. When I was doing my house job in Ahmad Bello University Teaching Hospital 10 years ago, it was, there were people who we've decided we're going to do this CS. We're all agreed the theater is ready, and we still have to wait 10 hours because the family is praying for hours. We're not going to do this. I bind it, I cast it. This is not going to happen. They have the resources, but there's that myth of if you deliver cesarean by cesarean section, you're weaker, or that affects your future outcomes. Technology and the advancements in medical care have gone beyond the point where cesarean sections are a death sentence or should be the cause of stigma. Like I said, it is still a matter of stigma in some parts of Nigeria if people deliver in the hospital at all, even vaginally. So there are bigger issues to unpack on that. But a lot of that is that the things that we need to do as people in the sector to enshrine that confidence is obviously regulation and safety. Like, how assured are people that if they do go with cesarean section, there are no complications that happen and that they get the best care? How are we making sure that people who are doing the cesarean sections are qualified to do it in the first place? And how do we ensure that ultimately communities or people understand the decisions that need to happen? I think a lot of the focus is also on reducing the number of emergency cesarean sections that we do, which then worsen the risk. Is part of the work that we're doing is some innovation by Gates Foundation that allows us check how does a woman know right from antenatal what her outcomes would be. So there's some it's called antenatal risk stratification, which is really from the moment she knows that she's pregnant, what are those 5 questions that you can ask, and you don't have to be a doctor to ask this question, that can allow you get a sense of what her outcomes look like and how can you proactively manage that. So that's kind of touching on the cesarean section and how that might be perceived, and maybe people who are still in gynecological practice could tell us if that's truly rising or if it's more better decision making and awareness that is averting deaths that could have happened from obstructed labor that we're now reading as, doctors are just doing CS for doing sake. Of course, I know many private facilities, or I've heard of private facilities that just section women without necessarily trying all of the different options that exist. But I would say that is the exception and not the case. For the most part, even as a clinician, it's much easier for you to have a safe, uneventful vaginal birth than, the process or the procedures of having to scrubbing and do the cesarean section. So again, regulation and making sure that we're taking the right decisions for every woman is critical. I wanted to talk a bit about the community engagement work that we're doing and how that's important. Like I said, we can all sit here in this room. We're educated. We went to school. We are of some privilege, and we always have to acknowledge that. We can sit here in this room or in our AC offices, in our cars, and cruise around and judge people who make these decisions, or just be far removed from the 800 in 100,000 live births that we're talking about. But like she said, these are human beings, these are people who could be contributing to the development of the country, people who have blood flowing in them, right? And at the same time, as we are thinking about solutions for them, part of the core of the work that we do is working with the communities to design what's going to work for them. And that's where human-centered design comes in. That's a key piece of sustainability. Like she said, if we want to solve brain drain, for example, we can call everybody together. But if we've not asked the health worker, what is that condition that you need to do to go to Zunguru, to stay there and do what needs to happen for you to save the lives in that family, then we're just going to be bringing up solutions that don't really work for the people who will benefit from it or who have to implement it. A lot of the work that we've also been doing has been anchored on this multi-sectoral approach that Dr. Adaeze mentioned, and most of the work that I do is vaccines work, but also maternal mortality prevention. And with vaccines, we know all of the different stories or the different issues that's centered around the topic of vaccines. I'm sure even if we sampled in this room, there are a lot of different perspectives on vaccines and what harm we perceive that they might cause. So part of the work that we do is using women collectives, because and doing that from the grassroots. So we've done the routine immunization body system, which is kind of bringing women together in groups and creating a social network out of them. Because again, in northern Nigeria, a lot of women do not gather socially to discuss any issues or to think about progressive development for themselves. So using women collectives, layering on that peer-to-peer education, making sure the messenger is someone who they trust. So a lot of vaccines is you have UNICEF, you have USAID, you have Bill Gates, and people are saying, I don't know this person, I don't trust this person, I don't already trust the health system or the government. You guys hoarded, sorry if you are one of the, sorry, people hoarded COVID palliatives, but then you're telling me these vaccines are free, these maternal health commodities are free. How do I get people to, the trust is not there. So how do you design with communities to make those things available, but also have messengers that are off the community? But then also layer on economic empowerment opportunities. So group businesses, group loans, working with SMEDAN and Nigeria Director of Employment and all of these organizations that are trying to do economic empowerment, those who are trying to do education, bring everyone together to then bring women into a group and say, okay, for instance, group antenatal care. We're all going to go to antenatal together. We're all going to be accountable for each other. We'll make sure we all deliver in the facility, and all of those things. So that women collective idea has kind of been used in different approaches for both maternal care as well as immunization with great success. And for the person who asked, you can Google Group ANC. You can Google CROWN, that's Community Reorientation Women Network. You can also Google routine immunization body system, RIBS. There's a few examples that have worked, and I think the media can amplify and do more with storytelling in that regard as well, to say what is possible and not just how bad the situation is. Thank you.
Thank you so much. Thank you. We are pressed for time, and I know there are a couple of us who were meant to ask questions, but I wish I had the luxury of a free press. But before we round up, I want to hear from you as regards any successes in community engagement as the digital health lead. Can you share to respond to that question?
Okay, so thank you very much. I feel like, actually, not even I feel, a lot of people, everybody here has given us some example or the other. Abiodun here has told us about his example with the Oyo State government, right? Raihanah has told us about what she's done with these several, public health programs. And Dr. Adaeze has also mentioned an example in India and the likes, right? So if you think about all those examples, you will see that there are successes. That's why they are being more or less retold here, right? But let's even take our mind back to like common health challenges that we even know about. Let's even start from what everybody knows about COVID, right? We say Nigeria had a, so to say, successful, outcome with the COVID, with our outbreaks and the likes. But what contributed to that? When NCDC is reporting, they're reporting how, first of all, there was a lot of government, engagement. Why how there's a lot of media, blowout. There's a lot of media engagement, a lot of like advocacy to people, enlightenment of the people and the likes. And that's how we were able to get a lot of people to wear masks. I mean, who wants to wear masks on a hot afternoon? People were able to wear masks. People stopped going to churches. Like, we are so religious. Who wants to not go to and pray in a praying ground? The way we were able to get to those successes because we had that collective, engagement, media also coming into to like spread that word out, right? Another common example I'm going to go into is HIV, right? Say early 2000s, you see someone who is really lean and the likes, everybody thinks this person has HIV, right? We are like, oh, HIV, everybody's like, this is a big pandemic. But over time, that has dropped, right? People who are progressing into more or less like HIV AIDS, to the AIDS part of it, which is like the deadly part of it, are much less because now more people are adopting the medication. More people are open to testing. More people are open to using prevention. How did that come about? You know those common jingles that said ABC. We know of those things. We know how campaigns came out. We know how in the hospitals people were like, let's test. Oh no, before you go get married, please test. The religious leaders are encouraging that before you get married, you must test, bring that test before you come to us, before we go ahead with the marriages. And those are like examples how people have, like, how in the different health, challenges that we've faced, you've had some form of like media engagement, some form of like community engagement, and that has led to some success in some way, right? And even when you think about HIV, that success has also spiraled down into maternity care. So you see that you have less children less children of people who are positive coming down with that disease because now they are more aware. Someone is telling them, this is what you can do to prevent your baby from getting this disease, and they are more inclined to take it up.
Wow, thank you so much. It's really been a very interesting and informative session. And these are replicable successes, yes, in different aspects, different projects, but very replicable. We will still have different opportunities to meet with our panelists and have asked those questions you would like to ask. On my own part, I'd like to end with this. I started by mentioning the maternal mortality rate. I mentioned it can be likened to having like a plane crash every day, 225 women. And it reminded me of a certain joke I heard about 3 people who were on a plane that was about to crash, and 4 people actually, and there were just 3 parachutes. And so the problem arose: who was going to get and who was going to crash? And the first person stood up and said, oh, I'm a big professor in my country. I am this. My country needs me. And so he took one of the parachutes and he jumped. The second person said, oh, I was the first man to innovate this, took the parachute and he jumped. And so it remained just one parachute, and then there was this young boy and this very old man. And the old man looked at him and said, anyway, my son, I've lived my life. You are young, so take the last parachute. I'm willing to just go with this plane. And the young boy said, oh, no, we have two remaining parachutes. And he's like, how come? He said, the last man jumped with my backpack. And yeah, so that was it. And the reason I brought this is because, we mentioned the plane crashing. Yeah, yesterday we had the incident of Abuja runway being closed because a plane kind of crash landed, and I happened to be on that plane. And somebody this morning said, oh, Chioma, when I saw the news, I didn't know you were on that plane. I was just praying. I just said, who knows who could be there? She just didn't believe anybody she knows would be there, And that's like something to take home with you. You can just sit back and say, oh, maternal mortality, this panel session, who you concern, you no concern me, right? As we say in Nigeria. But the truth is, you just can never tell who is going to be on that plane of maternal mortality. I pray it's not us. I pray it's not anybody who is close to us, but it doesn't stop us from please adopting whatever or contributing whatever we can to ensure that the goal, the SDG 3 goal, is realized by the year 2030. On that note, I want to say thank you for having us and have a great day.
Very much. Please just stand for a photo session. Please, let's put our hands together for the panel once more. Thank you. It's been wonderful, very engaging. We apologize that we couldn't take all of your questions because we're going to have a technical session later on, and this issue is part of the technical session. We'll take questions and interventions to that technical session. Is that okay, please? Please. Please, thank you. So let's also clap for ourselves that have been a part of this. We are indeed grateful to you all. Doctor and doctor and doctor and doctor and doctor. Thank you. And thank you for bringing a smile to all of us. Thank you.